Hi, my name is Bawany. I'm a third-year medical resident at TU1051 Medical Center, and I was asked by DDW to make a video presentation on the case which will be presented in May, annual meeting of DDW in May in Chicago, which is titled as An Unusual Suspect. We present a case, 48-year-old female with past medical history of peptic ulcer disease, which was being treated with omeprazole. She was referred to us by her primary care physician for diarrhea, which was not being managed with conservative management, and which was going on for a few weeks. On further questioning, patient mentioned that she has weight loss of 15 pounds in 3 months time period, and also had some lower abdominal pain, which was vague in nature, mild intensity, non-irritating. Her stool did not have any mucus, no blood, and denied any tenesmus. Her lab work from the physician revealed normal CBC, normal electrolytes, and stool was negative for any kind of infection. Her gastrin levels were negative, normal as well. She only had hypoalbuminemia and elevated alkaline phosphatase on her liver function test. Her family history was non-contributory, and her social history, like she denied any smoking or alcohol use. On examination, she was vitally stable and she looked cachectic on examination. Abdominal examination revealed mild epigastric tenderness. The rest of the examination was unremarkable. Considering the history of peptic ulcer disease and epigastric tenderness, she underwent elective upper endoscopy, which revealed enteral mucosa thickness with gastric ulcer, and Gastro-Colic fistula was seen on the palpebras. As you can see, these are the pictures from her EGD, and you can see the gastric ulcer on this picture. This is the second picture from the same procedure. It revealed the Gastro-Colic fistula, which was near the palpebras. And this is the third picture, which shows the colonic intubation, which was done with the upper endoscopy. Multiple biopsies were taken during the procedure, and all the biopsies came back as inflammatory process without any signs of malignancy. Patient underwent CT scan, which confirmed the fistulous connection between the stomach and the hepatic flexure of the colon, without any significant lymphadenopathy or mass was seen within the abdomen. Considering this, patient was treated conservatively with proton pump inhibitor and parenteral nutrition, and surgery consultation was done. Patient underwent expiratory laparotomy and takedown of fistula. After the surgery, patient was followed up with us in a couple of weeks, and her symptoms have improved significantly after the surgery. Our case was interesting in a point that it's a rare, gastric fistula is a very rare entity to be seen, and it's mostly seen in a malignant process. However, in this era of proton pump inhibitor and H2 blocker, it's very unlikely to see a Gastro-Colic fistula with benign peptic ulcer disease. The first case for Gastro-Colic fistula associated with malignant process was reported by Haller in 1855, and followed after that, and later in 1920, Firth reported a case of Gastro-Colic fistula secondary to peptic ulcer disease, which was benign in nature. Gastro-Colic fistula usually presents with three characteristic triads, which is nausea, diarrhea, and weight loss. Initially, the consideration was diarrhea because of the malabsorption, but in 1935, Haller came with the point that this diarrhea is secondary to the colonic content within the upper intestine, in the small intestine, causing absorptive problem in the small intestine. In the end, I would just like to mention that it's Gastro-Colic fistula is a rare entity, and it has to be considered like lower in the deficiency.